Tell me about your experience with different types of vascular access devices.
I have extensive experience with a variety of vascular access devices, which is a critical skill for any nurse. My proficiency spans from basic peripheral intravenous for catheters to more complex central lines, including PICC lines and midlines. I am well versed in the insertion of peripheral IVs, demonstrating a strong ability to select the correct vein and gauge size, and to ensure proper site care to prevent complications like infiltration or phlebitis. My experience also includes the management and care of central lines, such as central venous catheters and peripherally inserted central catheters, PICC lines. I am skilled in performing sterile dressing changes, flushing the lines to maintain patency, and meticulously monitoring for signs of infection or other complications. I understand the crucial importance of following strict sterile technique and hospital protocols for these devices to prevent life-threatening bloodstream infections. My knowledge extends to midlines as well, and I can differentiate between the indications, care requirements, and potential risks of each type of line. I believe that the proper selection, insertion, and maintenance of a vascular access device are paramount to patient safety and comfort. I always assess the patient's individual needs and the intended therapy before choosing the appropriate device. This comprehensive experience allows me to manage vascular access with confidence, ensuring patient safety and contributing to a positive clinical outcome. I am confident in my ability to handle the specific vascular access needs of your patient population.
Describe the process for placing a PICC line from start to finish.
As a registered nurse, I have assisted with and managed many PICC line placements. The process for placing a PICC line is a meticulous, multi-step procedure that requires strict adherence to sterile technique and protocols to ensure patient safety and prevent infection. The process begins with a thorough patient assessment, where the patient's medical history is reviewed and an appropriate vein is chosen, usually in the upper arm. The nurse also assesses the patient's understanding and willingness to cooperate with the procedure, ensuring they are comfortable and have a good understanding of what is happening. The actual procedure is performed under sterile conditions. The nurse performing the insertion will wear sterile gloves, a gown, and a mask, and will also drape the area around the insertion site. The area is cleaned with an antiseptic solution to minimize the risk of infection. The PICC line is then inserted into the vein and guided under ultrasound guidance toward the superior vena cava. Throughout this process, the nurse maintains a professional dialogue with the patient, reassuring them and addressing any discomfort they might feel. Once the catheter is in place, the nurse secures the line with a sterile dressing and a sutureless securement device. This is followed by a chest X-ray to confirm the tip placement of the PICC line. It is crucial that the tip is correctly positioned before any infusion begins. Finally, the nurse educates the patient and their family on how to properly care for the PICC line at home, including dressing changes, what to look for regarding infection, and what to avoid. This comprehensive process, from start to finish, ensures the line is safely and effectively placed, minimizing risk and maximizing patient comfort and positive outcomes.
How do you handle a difficult venous access case?
Handling a difficult venous access case is a common challenge for nurses and requires a combination of clinical skill, patience, and a methodical approach. My strategy is to first perform a thorough, hands-on assessment of the patient's veins. I'll ask about their history with IVs, look for any scars or collapsed veins, and consider factors like dehydration or edema. I don't just look at one potential site, I will check multiple locations on both arms, considering the patient's comfort and mobility. Once I've identified a potential site, I use a variety of techniques to improve venous visibility and access. These might include applying a warm compress to the area to encourage vasodilation, having the patient dangle their arm, or using a tourniquet to make the vein more prominent. If the initial attempt is unsuccessful, I'll pause, take a moment to reevaluate, and then try a different location or a small gauge catheter. I believe in using available technology to my advantage. In cases where the veins are particularly challenging, I would use an ultrasound or a vein finder device. These tools provide real-time visualization of the vein, which significantly increases the chance of a successful insertion on the first attempt and reduces patient discomfort. If after a few attempts I am still unsuccessful, I would not hesitate to involve a colleague or the charge nurse who has more experience with difficult cases. This collaborative approach ensures that the patient receives the care they need without unnecessary distress, and it is a testament to my commitment to patient safety and teamwork.
What is the proper protocol for managing a central line-associated bloodstream infection?
Managing a central line-associated bloodstream infection, CLABSI, is a top priority for patient safety and requires immediate, systematic action based on established international protocols. My protocol begins with prompt recognition and assessment. As soon as I suspect a CLABSI, indicated by signs like fever, chills, or redness and tenderness at the catheter site, my first step is to notify the attending physician immediately and prepare to obtain blood cultures. The next crucial step is diagnostic confirmation. This involves drawing blood samples for culture from both the central line and a separate peripheral vein. This allows the lab to determine if the same organism is present in both samples, which helps confirm the central line as the source of the infection. It's vital that these samples are collected before any antibiotics are administered, as this would compromise the results. Once a CLABSI is confirmed or highly suspected, the medical team will make a decision on whether to remove the central line. While a salvage attempt might be considered in some cases, international guidelines from organizations like the Centers for Disease Control and Prevention (CDC) and the Infectious Diseases Society of America (IDSA) often recommend immediate removal, particularly if the patient is severely ill or the infection is caused by specific, hard-to-treat organisms. Finally, I would administer appropriate antimicrobial therapy as prescribed by the physician, ensuring that I follow the hospital's protocols for medication administration and monitoring. I would also meticulously document the entire process, from the initial signs and symptoms to the final treatment, to ensure a complete and accurate record for the patient and for infection control purposes.
Explain the difference between a midline and a PICC line.
A midline catheter and a PICC line are both types of vascular access devices, but they differ significantly in their length, tip location, and the type of therapy they can be used for. Understanding these differences is crucial for a nurse to select the correct device for a patient's specific needs. The primary difference lies in the tip location. A midline catheter is a peripherally inserted catheter that is shorter in length. Its tip terminates in one of the larger veins of the upper arm, specifically in the axillary vein, no further than the level of the shoulder. Because of its shorter length and tip location, a midline is generally used for therapies that are expected to last for a shorter duration, typically from 1 to 4 weeks. It is suitable for most fluids, antibiotics, and pain medications, but it cannot be used to administer vesicants, which are drugs that can cause tissue damage if they leak out of the vein, nor can it be used for total parenteral nutrition (TPN). In contrast, a PICC line, or peripherally inserted central catheter, is much longer. It is also inserted into a peripheral vein in the arm, but it is threaded much further. Its tip terminates in a large central vein, either the superior vena cava or the cavoatrial junction. This central tip location allows the PICC line to be used for a much wider range of therapies, including long-term antibiotic administration, chemotherapy, and TPN. Because the medication is delivered into a large vein with a high blood flow rate, the risk of damage to the vessel wall from vesicants is significantly reduced. PICC lines can remain in place for weeks or even months, making them ideal for long-term care needs.
What are the common complications associated with vascular access devices, and how would you manage them?
Common complications associated with vascular access devices range from minor issues to life-threatening conditions, and a nurse's ability to identify and manage them is critical for patient safety. The most common complications I encounter are phlebitis, infiltration, and infection. Phlebitis is an inflammation of the vein, often caused by mechanical irritation from the catheter or a chemical reaction to the infusate. Signs include pain, redness, and swelling along the vein. My management would involve removing the catheter, elevating the limb, and applying a warm compress to the affected area. I would then document the incident and find a new site for venous access. Infiltration occurs when the fluid or medication leaks into the surrounding tissue instead of flowing into the vein. I would notice this by the swelling, coolness, and pain around the insertion site. My first action would be to immediately stop the infusion and remove the catheter. I would elevate the limb and apply a warm or cold compress as per protocol, depending on the type of fluid that infiltrated, and then find a new site. Infection, while less common, is a more serious complication. I would be vigilant for signs like fever, chills, redness, pus, or a foul odor at the insertion site. If I suspect an infection, my immediate priority is to alert the physician and follow the established protocol, which often includes obtaining blood cultures and considering the removal of the device. In all cases, my approach is proactive. I routinely assess and inspect the insertion site for any signs of these complications, and I am meticulous with my sterile technique during every dressing change to prevent them from occurring in the first place. I also educate my patients on what signs to look for so they can be active partners in their own care.
How do you ensure proper patient education regarding their vascular access device?
Effective patient education regarding a vascular access device is essential for ensuring patient safety and promoting a positive recovery. My approach to this is systematic and empathetic, ensuring that the patient and their family understand the device, its purpose, and how to care for it. The process begins with an initial conversation during the insertion or management of the device. I explain why the device is necessary using simple, non-medical language. For instance, I might say, "This line will make it much easier to give you your medication without having to poke you with a new needle every time." This helps the patient understand the benefit and rationale behind the device. I then provide clear, concise instructions on how to care for the device. I cover key topics such as site care, emphasizing the importance of keeping the dressing clean and dry. I instruct them on what to look for, such as signs of infection, including redness, swelling, or pain. I also explain what activities to avoid, like heavy lifting or getting the site wet. I make sure to demonstrate proper hygiene techniques, such as hand washing, and provide them with written materials they can reference later. Finally, I use a teach-back method to confirm their understanding. I will ask the patient to explain the care instructions back to me in their own words. This helps me identify any areas of confusion and allows me to correct any misunderstandings before they go home. By empowering patients with this knowledge, they become active partners in their own care, which significantly reduces the risk of complications and leads to better overall outcomes.
Describe your approach to patient and site assessment before and after device placement.
My approach to patient and site assessment for vascular access devices is a two-part process: a thorough assessment before placement to ensure success and safety, and a continuous assessment after placement to monitor for complications. Before placing any vascular access device, my first step is to assess the patient's overall condition and medical history. I review their hydration status, any known allergies, coagulation disorders, or a history of difficult venous access. This is followed by a meticulous site assessment. I visually inspect both arms for suitable veins, looking for those that are straight, palpable, and free from scars, bruises, or recent punctures. I use a tourniquet to make the veins more prominent and consider the patient's comfort and mobility. For central lines or PICC lines, I would also consider the patient's long-term needs, the type of therapy, and any planned surgeries to select the most appropriate insertion site and device. My goal is to find a vein that is not only accessible, but will also support the intended therapy with the lowest risk of complications. After the device is successfully placed, my assessment becomes a continuous process to ensure the site remains healthy and the device is functioning properly. During every shift, I perform a thorough visual inspection of the insertion site, checking for signs of infection such as redness, swelling, drainage, or warmth. I also check for signs of infiltration or phlebitis, which can be indicated by pain or tenderness around the site. I would also palpate the area to check for any tenderness or cord-like veins. Additionally, I would assess the patency of the line by flushing it with saline to ensure there are no occlusions or resistance. I also ask the patient if they are experiencing any pain or discomfort. Any findings, no matter how small, are documented meticulously. My continuous assessment approach ensures that potential issues are identified and addressed early, preventing complications and maintaining the safety and integrity of the vascular access device.
How do you maintain sterility during a procedure?
Maintaining sterility during a procedure is a fundamental responsibility for nurses, and it is a critical practice for preventing healthcare-associated infections. My approach is systematic and based on established protocols to create and preserve a sterile field. The process begins long before the procedure itself, with a thorough hand hygiene routine. I ensure my hands are completely clean with either a surgical scrub or an alcohol-based rub, depending on the procedure, as this is the first line of defense against microorganisms. Next, I meticulously prepare the sterile field. This involves checking the integrity and expiration date of all sterile packages. I then open them carefully, ensuring I touch only the outer packaging and use sterile forceps or a gloved hand to place items onto a sterile drape. I am extremely conscious of the sterile-to-sterile and unsterile-to-unsterile principles, meaning I only allow sterile items to touch other sterile items and never turn my back on a sterile field to prevent any airborne contamination. Throughout the procedure, my attention to detail is unwavering. I avoid reaching over the sterile field, maintain a safe distance from it, and continuously monitor for any potential breaches. If a sterile item is contaminated, for example, if a wrapper touches the floor or my ungloved hand, I immediately remove it from the field and replace it with a new sterile item. This proactive and meticulous approach, coupled with my understanding of aseptic technique, ensures that I can maintain a sterile environment and protect the patient from infection during any procedure.
What steps do you take to prevent complications such as phlebitis or infiltration?
Preventing complications such as phlebitis and infiltration is a top priority in my nursing practice, and my approach is centered on meticulous attention to detail and proactive patient monitoring. The steps I take begin before the insertion of the vascular access device. I first perform a thorough site assessment to select the most appropriate vein. I look for a straight, healthy vein in a location that will not be easily irritated by movement. I also choose the smallest gauge catheter possible to accommodate the prescribed therapy, as a larger catheter can cause more trauma to the vessel wall. Once the catheter is in place, my focus shifts to continuous and vigilant monitoring. I routinely assess the insertion site during every shift and before every medication or fluid administration. I am constantly on the lookout for early signs of complications, such as redness, swelling, tenderness, warmth, or coolness around the site. I also check for any signs of fluid leaking from the site, which can indicate infiltration. I ensure that all dressings are secure, clean, and dry to prevent infection, and that the catheter is properly stabilized to prevent it from moving and irritating the vein. I educate my patients on what to look for and encourage them to report any discomfort immediately. I also make it a practice to assess the patency of the line by flushing it before and after medication administration, which helps ensure the fluid is flowing correctly and not leaking into the surrounding tissue. This proactive hands-on approach allows me to identify and address potential issues before they can escalate into more serious complications.
How do you verify the correct tip placement of a central venous catheter?
Verifying the correct tip placement of a central venous catheter is a critical safety step that must be performed before the catheter is used for infusions. My process for this involves a combination of methods, primarily relying on diagnostic imaging to confirm the final position. The standard and most reliable method is a chest X-ray immediately following the insertion of the central line. The physician or a qualified nurse will order this X-ray to visually confirm that the catheter tip has been advanced to the correct position, which is typically in the lower third of the superior vena cava, just above the right atrium. I would never use the line for fluid or medication administration until I have received confirmation from the physician that the X-ray shows the tip is in the proper location. This is a non-negotiable step to prevent serious complications like cardiac arrhythmia or vessel damage. In some hospitals, other methods are used in conjunction with or as an alternative to X-ray. For PICC lines, a CVC tip navigation system using a special tip positioning device can provide real-time location tracking during insertion, which can be an excellent adjunct. Another method for some central lines involves connecting the catheter to a transducer to measure the patient's intracardiac pressure. The pressure waveform changes as the catheter tip nears the heart, which can help guide placement. However, regardless of the method used, the final verification with a chest X-ray remains the gold standard for most central lines. By adhering to this strict protocol, I can ensure the safety and effectiveness of the central venous catheter.
A patient's PICC line is occluded. What are your first steps?
An occluded PICC line is a common but serious complication that requires immediate and systematic intervention to restore patency and ensure the patient can continue their therapy. My first step upon discovering an occlusion is to assess the situation and the patient. I would check for any signs of swelling, pain, or redness around the site that might suggest a thrombotic event or a malposition of the line. I would then attempt to gently flush the line with a saline syringe, but I would never force the flush if there is any resistance, as this could dislodge a clot and cause a pulmonary embolism. If the gentle flush is unsuccessful, my next step is to use the SBAR, situation, background, assessment, recommendation communication tool to contact the attending physician. The SBAR framework allows me to give a concise and clear report of the patient's status and the issue with the PICC line. For example, I would state the situation PICC line is occluded, provide the patient's background, why they have the PICC line and their medical history, my assessment, no signs of infection or swelling, unable to flush, and my recommendation requesting an order for a thrombolytic agent like alteplase or TPA, or an order to remove the line. Once I have a new order from the physician, I would administer the prescribed thrombolytic agent directly into the PICC line as per the hospital's protocol. The medication is typically left in the line for a certain amount of time to dissolve the clot. After the dwell time, I would aspirate the medication and the clot and then flush the line to test for patency. Throughout this process, I would meticulously document every step to ensure a complete and accurate record of the event.
You notice a sudden change in a patient's vital signs during a procedure. What do?
A sudden change in a patient's vital signs during a procedure is an immediate red flag that requires a quick, calm, and systematic response. My first action would be to stop what I am doing and focus entirely on the patient. I would not assume the change is benign. My immediate next step is to perform a rapid ABC, airway, breathing, circulation assessment. I would check the patient's airway for patency, assess their breathing for rate and quality, and quickly check their heart rate and blood pressure. While doing this, I would also mentally review the situation to see if there is a clear cause, such as a reaction to a medication that was just administered. I would then call for help using the established hospital emergency protocol, whether that's activating a rapid response team or calling a code. While waiting for the team to arrive, I would not stand by idly. I would quickly perform a more detailed assessment, looking for other signs of distress, such as changes in the patient's level of consciousness, skin color, or pain level. I would also have any emergency equipment, such as an oxygen mask or a crash cart, ready at the bedside. My communication with the incoming team would be clear and concise, using the SBAR framework to provide a quick summary of the situation. This ensures they have all the critical information they need to intervene effectively and immediately. My ability to remain calm under pressure, prioritize patient safety, and communicate clearly is paramount in these high-stakes situations.
A patient's family member is anxious about the procedure. How would you handle this situation?
When a patient's family member is anxious about a procedure, my primary goal is to provide reassurance through clear, compassionate communication and professional expertise. My approach is centered on two key principles: empathy and education. First, I would acknowledge their feelings and provide a quiet, private space to speak. I would calmly sit with them at their eye level and listen attentively to their concerns without interruption. For example, I might say, "I can see that you're worried about your loved one. Please tell me what's on your mind." This simple act of validating their anxiety builds a foundation of trust. I would answer their questions honestly and patiently, using simple, non-medical language to explain the procedure and why it is necessary. I would also explain my specific role in the procedure and reassure them that the patient's safety is my highest priority. Second, I would manage their expectations by providing a realistic timeline for the procedure and a clear plan for follow-up communication. I would let them know when and where they can wait and when I or the physician will provide an update. I'd also make sure they know who to ask for if they have questions while they wait. If they are still very anxious, I would offer to connect them with a social worker or a chaplain who can provide additional support. By addressing their emotional needs and providing them with concrete information, I can help alleviate their anxiety and empower them to feel like a part of the care team. This approach transforms a moment of stress into one of shared understanding and support.
Describe a time you encountered a challenging situation related to vascular access and how you resolved it.
During a night shift, I was assigned to a patient who required a stat infusion of medication, but her venous access was extremely challenging. She was an elderly patient with a history of intravenous drug use, which had severely compromised her peripheral veins. My initial assessment revealed that all her superficial veins were either collapsed, sclerosed, or had signs of previous punctures, making a standard peripheral for impossible. This was a challenging situation because the medication was time-sensitive, and delaying it could have negatively impacted her outcome. My first step was to not rush and to avoid multiple unsuccessful attempts, which would only cause the patient more distress and further damage her veins. Instead, I paused and assessed the situation from a broader perspective. I understood that this was a problem requiring a more advanced solution. I informed the charge nurse about the situation, and we collaborated on a plan. We decided that a more central access point was necessary. My immediate action was to prepare for and assist with the insertion of a central line. I gathered all the necessary equipment, ensure the area was prepared for a sterile procedure, and reassure the patient about the process. While the physician placed the central line, I continuously monitored the patient's vital signs and provided emotional support. After the line was successfully placed and verified with a chest X-ray, I was able to administer the medication safely and on time. This experience reinforced the importance of critical thinking, collaboration, and knowing when to escalate a problem to a higher level of care. It highlighted that sometimes the best solution is not a quick fix, but a safe and well-planned intervention.
How do you collaborate with physicians and other nurses to ensure optimal patient care?
Effective collaboration with physicians and other members of the healthcare team is essential for providing optimal patient care, and I view it as a cornerstone of my nursing practice. My approach is centered on clear, concise, and professional communication. When communicating with a physician, I use the SBAR, Situation, Background, Assessment, Recommendation framework. This structured method ensures that all critical information is conveyed quickly and accurately, preventing misunderstandings and supporting timely decision-making. For example, if a patient's condition changes, I would not just say, "The patient looks unwell." Instead, I would provide a specific SBAR report that includes the situation, the patient's status, the background, their medical history, my assessment, the vital signs, and my clinical findings, and a clear recommendation, what I believe needs to be done. This proactive and professional communication style builds trust and ensures that the physician has all the information they need to provide the best care. With other nurses, I believe collaboration is about teamwork, respect, and mutual support. I make it a priority to provide a comprehensive and clear handover at the beginning and end of each shift, ensuring continuity of care. I am always willing to assist a colleague, whether they need help with a difficult procedure or just need an extra hand with a patient. When a conflict or a disagreement arises, I address it directly and professionally, always keeping the patient's well-being as the top priority. I believe that a cohesive and supportive nursing team is a safer team, and I am committed to contributing to a positive and collaborative work environment.
How would you educate a new nurse on proper vascular access techniques?
To educate a new nurse on proper vascular access techniques, I would take a structured and hands-on approach, combining theoretical knowledge with practical application. I'd begin with a foundational review of the principles of vascular access, covering the types of devices, such as peripheral IVs and central lines, and their specific indications. We'd discuss proper vein selection, emphasizing the importance of a thorough patient and site assessment, and the use of tools like ultrasound or vein finders for difficult cases. I would also stress the critical role of maintaining a sterile field and using meticulous hand hygiene to prevent infections. Once the theoretical foundation is set, we'd move on to hands-on training. I would start by demonstrating the procedure myself, explaining each step as I go and answering any questions they have. I would also talk them through my thought process, such as how I choose a vein and what signs I look for. After my demonstration, I would supervise their attempts, providing real-time feedback and positive reinforcement. I believe in a supportive learning environment, so I would encourage them to ask questions and discuss any challenges they encounter. I would not just tell them what to do, but would also explain the why behind each step, connecting the technique back to patient safety and positive outcomes. Finally, I would emphasize the importance of continuous learning and professional development. I would provide them with resources, such as hospital protocols, best practice guidelines, and educational materials. I'd also encourage them to debrief with me after difficult cases. This comprehensive approach ensures the new nurse not only gains technical skill, but also develops the critical thinking and confidence needed to provide safe and effective vascular access care.
Tell me about a time you had to deliver difficult news to a patient or their family.
Delivering difficult news is one of the most challenging but crucial aspects of a nurse's role. It requires both empathy and clear communication. A time that stands out was when a young patient, a teenager, was diagnosed with a chronic illness that would significantly change his life. The medical team had confirmed the diagnosis, and it fell to me, as his primary nurse, to assist the physician in informing the family. My role was to prepare the family for the conversation and to be a source of support afterward. I first took the parents to a private room, offering them some water and a moment to collect themselves. I used a calm and gentle tone to explain that the doctor would be coming in shortly to discuss the test results, reassuring them that we were all there to support them. During the conversation with the doctor, I stayed present in the room. I observed the family's nonverbal cues and emotional state. When the parents looked confused or overwhelmed, I would gently interject to clarify a medical term or to summarize a point in simpler language. I also made sure to give them space to react and ask questions, never rushing the conversation. After the physician left, I remained with the family. They were understandably emotional and had many questions about what the diagnosis meant for their son's future. I provided them with a quiet, supportive presence, answered their immediate questions about medication and care, and connected them with a social worker and a support group. My focus was on ensuring they felt heard, understood, and not alone. This experience taught me the immense importance of not just delivering information, but of providing compassionate support and resources to help families navigate through such profound and life-altering moments.